is BioMedicine Institute. Today I, Dr. Pramod Khatri, is going to represent a simple topic named as principles of transplantation. So transplantation, the basic definition is to transfer an organ or a tissue from one part or individual to another. It may take place between different parts of the same organism like autografting, different organisms of same species like allografting, or even different species like xenografting. The basics are the tissue from another source is grafted into a host. Host either recognize the graft as self or accept it, or recognize it non-self, or an immune response can develop against it. The immune response destroy the graft, and local vascular tissue, they can reject it. So autografting, basically the example of graft acceptance are the transfer of self tissue from one body site to another in the same individual. Due to genetic homology of the tissue, the immune system does not respond to it. There are many uses like skin graft, bone marrow transplantation, system cell transplantation, or synthetic implantation. Now comes the rejection. When the immune system of the host detects foreign graft tissue, it launches an attack, resulting in tissue rejection. There are two stages. First one is sensitization stage, and second one is your effector stage. Three clinical manifestations or more can be there, like your hyperacute, acute, or chronic. There is in the stage 1, which is also known as sensitization stage, antigen recognized by the T cells trigger lymphocyte proliferation. Antigen, the portion of graft HLA complex or MHC, major histocompatibility, are processed and presented. Minor histocompatibility complex also play a role. They do not need to match exactly, but multiple mismatch can trigger rejection. Important here is the major histocompatibility can be recognized directly by the T cells. Minor histocompatibility must be processed and presented by the APC cells. Stage 2, or we can say effector stage. The host immune system attack the graft, destroy it with 4 methods. The first 2 methods are important, like CTL mediated cytotoxicity, delayed type hypersensitivity, antibody dependent cell mediated cytotoxicity, and complement mediated lysis. Now comes the clinical transplantations. Many human disease or disorders are caused by defect in organ or in tissues. The transplanted organ can replace organs that are defective or damaged by a disease. Improved surgical technique have made many different types of tissue grafting possible. This is a clinical picture of a transplantation where we can get the transplantation for our skins. Mostly autologous. If there is a burn victim, they can be temporary graft of non-viable tissues. Allogenic graft, which are again rare or require immunosuppression. For blood, they can be transfused by the living donor like A, B, O, and RH. Matching requires. Complications extremely are rare, and an estimated 14 million units used every year. Pancreas from cadavers. Islet cells from organ are sufficient. Till date, in 1998, 253 transplants were carried out, and it is basically increasing in advanced diabetes. Kidney, from liver donor to cadaver, and basically ABO and HLA matching are helpful, are useful. Immunosuppression is usually required. The risk of GVHD is very low, and in 1998 there were 12,000 almost transplants. There can also be a bone marrow transplant, and needle aspiration from the liver donor is inserted, implanted by IV injection. ABO and HLA matching required, and the rejection rare, but GVHD is at risk. Liver can also be transplanted from the cadaver. The surgical implantation are complex. Resistance to hyperacute rejections increases, and there is a risk of GVHD, and in 1998 there were 4450 transplants. Heart. from brain dead donor. It can be transplanted. HLA matching, useful but often impossible. Risk of coronary artery damage, perhaps mediated by host antibody. So in 1998, 2340 heart were transplanted. Lungs can also be transplanted from brain dead donor. Procedure is recently being developed and detailed data is available. And in 1998, 845 lungs were transplanted, and often heart lung transplant were carried out. They are being carried out, and cornea, eye, can also be transplanted from the cadaver. And immunosuppression is basically not needed. And almost 40,000 cornea transplants are going on every year in the world. So the milestones in the transplantations are in 1682. Bone from a dog is used to repair human skull. In 1881, this is known as the earliest skin graft from the frog skin. In 1930, Carl Landsteiner awarded Nobel Prize for discovering ABO blood group. In 1945, P.B. Mendawer published a paper linking graft rejection and immune system. In 1954, first successful kidney transplant was between identical twins. In 1967, first successful heart transplant was carried out. In 1990s, first living donor lung transplant was carried out. In 1992, a patient received a baboon liver and survived for 2 months. In 1995, an HIV/AIDS patient received a bone marrow transplant from chimpanzee. And in 2002, first liver transplant between identical twins was performed without using immunosuppressant medicines or drugs. So there can be a hyperacute rejections which usually take place between 24 hours of transplantation, and the serum antibody react to foreign major histocompatibility complexes triggering complement system. The interest of neutrophils and the inflammation cause clot formation in the blood vessels, and the graft dies without being vascularized. But where do these serum antibody come from? Next comes the acute rejection. Basically, these are two-stage process, and the good old-fashioned immune, it is a good old-fashioned immune response. And within 2 weeks of transplantation, macrophage and lymphocyte, they will swarm the tissue, triggering cytotoxicity, complement activation, and graft cell lysis. The 2-week delay is indicative of the TH activation time. Now comes chronic rejection. Even if a graft escapes an immediate rejection response, it can undergo rejection every year. Tissue typing and immunosuppression drugs decrease the likelihood of a chronic rejection, but they have a long way to go. If the rejection cannot be managed, another transplant may be necessary. Of course, due to memory and specificity of immune system, subsequent rejection occur even more quickly and vigorously. There are various zones of immunological privilege. Transplant into zone of immunological privilege have proven highly successful. For example, since there are a few blood vessels in the cornea, there is a low rate, about 20% of corneal graft rejection. There have been some success transplanting fetal pig neural tissue into the brain of Parkinson's disease patient. So now comes graft versus host disease. Lymphocytes from the donor are carried by the organ into the body of the graft recipient. If the recipient is immunocompromised, the foreign lymphocytes can attack his tissue, resulting in skin rashes, interstitial problems, organ failures, and death. Liver, spleen, bone marrow transplant also carry the risk of GVHD. So there are various barriers for medical transplant. Difficulty posed by the immune system. The necessity of major histocompatibility matching makes it harder to find compatible organ. Repeat graft recipient reject new organs. faster and more vigorously with each new transplant. Shortage of available organs are many transplantable organs can only be taken from cadavers. Organs must also match from size and conditions. Now comes the immunosuppressive therapy, which is basically non-specific drugs that interfere with immune response. This attenuates the rejection of donor tissue, decrease immune responsiveness, increase susceptibility to pathogens and cancer. Current therapy involve use multiple drugs in low dose. The goal of this is to minimize side effect while still preventing rejection. Many immunosuppressives are derived from fungi. Why? This is a diagram of a cyclosporin A. Now comes the specific. The treatment that produce an immunodeficiency specific to donor alloantigens, and it is basically an artificial hole in repository. Monoclonal antibodies can block T cell activation and binding, extending the life of transplanted organs. Soluble fusion proteins can be made with block costimulatory signal cells from T cell activation. Xenotransplantation. Basically, it is the transfer of tissue from one species to another. Usually refers to transplantation of animal tissue in human beings. Many different types of tissues they can be transplanted. Using animals for organ would provide a vast new source of organs for human beings. The clinical aspects are attempt like kidney, heart, liver, bone marrow, transplant from primates into human have met with little success. The earliest xenotransplantation of a chimpanzee kidney to human took place in 1964. In 1993, T.E. Stalls performed 2 liver transplants from baboons into the patient suffering from the liver failure. Both died within 70 days. Pigs have also been considered as a source of organ, especially kidney. Now, there are various problems with xenotransplantation. Even with immunosuppressions, the foreigners of animal tissue provoke a vigorous immune response. Virus and disease which have no ill effect in animals have the potential to cause serious illness in humans. Animal retrovirus may combine with human variants, producing dangerous new pathogens. So these are the various problems with xenotransplantation. So the solutions are animal breed with human histocompatibility genes like your transgenic animals. They can be helpful. Would have a organ immunologically indistinguishable for human organ. Other transgenic organs might produce protein that prevent destruction by complement system. So basically the solution here is production of transgenic animals. Summary. Graft antigens in the form of major histocompatibility and bound ligands are recognized by host lymphocytes, mostly important Th cells. The resulting cell-mediated response destroys graft tissue, which undergo necrosis. In future transplant, serum antibodies may trigger antibodies mediated or hyperacute rejection or specificity and memory. So I hope you have gained a lot of clinical information through this presentation. Please like, share, subscribe our YouTube channel named as British Biomedicine Institute. Good luck, goodbye.